And it's my pleasure to introduce our next speaker, Tina Tellem, who is from Oslo, working in Oslo in Norway, has been on her travels at times and has worked in London as well. And I don't know if elsewhere, Tina, but that's where I know you've been at least anyway. Tina has a big sort of research background in looking at uterine pathology, very well known for adenomyosis, and also but today I've asked Tina, I think it's really, I have to say, I find when I have a lady with enormous fibroids, my heart slightly sinks when I get to things saying, when I'm thinking, we're going to have to map all of these fibroids, is it relevant? And frankly, slightly. So I'm very interested to see what you have to say. But I think there's two issues of fibroids, looking at them and actually what impact they have on fertility, and do you actually have to do anything about them? And this is, I think, quite a perhaps controversial. I don't know, Tina, what do you think?
Thank you for introducing me. Yes, I think it's controversial, and I think it's difficult to answer this. So thank you for the kind introduction again, and having me on this course. I hope that I can, let me just share my screen now. Can you see my presentation?
Perfect. Yes.
Yes. So I hope that the level really meets what the needs of the participants, and please ask me any questions. So fibroid mapping and impact on fertility. I will just start with my disclosures. I get fees from various companies for talks, but it's not related to my research or this talk. And the topics is what is actually fibroid mapping, why we should do it, the how I do it, then the impact of fertility on fertility of fibroids, and then I also want to give you a little overview of unusual appearances of fibroids. So what is actually fibroid mapping? Actually, there is no fixed term or the manual, like this is what everyone does, but it is actually the proper way of reporting, as Tom said. So it means you should document every visible fibroid. You should document the location, meaning if it's where it is located in the uterus, if it's anterior, posterior, left, right, where high up or in the fundus or isthmic, the FIGO type, we will come back to this. Then the size in 3 dimensions. 3 dimensions, as was mentioned before, is really important in order that we can assess growth. Fibroid is this is a volume, and the shape is not always a ball sphere, but it can be oval and so on. So 3 dimensions is important. And then you can also, if it's necessary, document if there's unusual features. And what I really like to read in a report and also to put into a report is the potential clinical significance. So is this really necessary? I mean, women can have so many fibroids and it can be really, really painful. And I can answer that question to you. Obviously, I do it. I hate it and I do it. And but I want to work with you together on the answer. Maybe you yourself can answer this. So let's start with a FIGO myoma classification that was introduced in 2012. And I find this really useful, and I recommend everyone to have it, to print this out and have in your office, because it can be a lot to ask to remember each one of them. So they're numbered from 0 to 8, depending on where they are located. Type 0 is pedunculated inside the cavity. Type 1 is more than 50% inside the cavity and less than 50% intramural. Type 2 is also submucous and more than 50% inside the wall. So the location and the extent, how much they are located inside the wall, is really relevant, both for surgery and later on also for fertility. The others will then be be all intramural, touching the endometrium from inside, the wall from the myometrium. Type 3, then 4, 5, 6, and 7. Finally, 8 being located in the cervix. So looking at this, we can decide what the impact of those fibroid is on fertility. And here is the limitations of the studies right away, because I can give you the short answer: we don't know. Because the studies are limited, most of the studies that are published do not use this FIGO classification. They're older. They came in a time before FIGO was done, so we don't know what they really compare. Most studies are also performed in artificial reproductive settings in IVF clinics. So this is infertile patients, this might not apply to your patient. Most studies are retrospective. And also fibroids are associated with age. And we also know that age massively affects fertility. So it's really difficult to find an answer. And also the studies look at different things. Some look at live birth rate, which is really what counts for the patient, right? They want a baby to take home. They're not so interested in just getting pregnant. They want to take the baby home. And other studies look at clinical pregnancy age, miscarriage rates, or implantation rates. So if we look at studies showing that there is an impact of fibroids on fertility, we have two reviews. They're quite old, from 2008. And they show that submucous fibroids do affect fertility. Those would be, they have specified again very detailed in which of those types. And there's another study from 2010. They said that also cavity non-fibroids might have an impact on live birth rate and clinical pregnancy rate in artificial reproduction. Those would be this number 6 and 5. A recent study from 2016 showed that non-cavity distorting fibroids, also 6, 5, and 4, that are over 3 centimeters, can affect the live birth rate and also clinical pregnancy rate, again in an IVF. And then the most recent study showed that type 3, this is intramural, touches the endometrium, can have a negative live birth rate, clinical and implantation rate, but very interestingly, not miscarriage rate. But there's other studies showing, more recent, showing that there's no fibroids of fertility, for example, from Steyer et al. From Fertility and Sterility 2017. And they showed that non-cavity, cavity non-fibroids have a higher miscarriage rate, but no difference in conception or live birth rate. Again, the outcome we are interested in. Platsky showed in a study looking at women that had oocytes donors, so there the age factor was less relevant, and there showed that neither clinical pregnancy rate or implantation rate were affected by fibroids, and this was any types. Elder Gebar in a study showed that there was no effect of subserous fibroids, so those that are outside the cavity. And then Metvali in a review also showed that there was no effect of intramural fibroids on artificial reproduction. And two studies looking at endometrial receptivity, so at the more molecular level, could also not show that intramural fibroids and those that didn't distort the cavity had an effect on endometrial receptivity. So I managed to confuse you by this. And the easy solution could just be, okay, if we don't really know, why not just remove it? And then we have two Cochrane works, a 2020 update, where there was the group to management of fibroids for subfertility, and they could not conclude that myomectomy has improved clinical pregnancy rate or miscarriage rate for intramural submucous, or intramural subserous fibroids. So there might be, there's of course a problem with the evidence. We don't have good enough studies, but there might be also other factors than just the mechanical affection. There might be a lot of molecular that are not understood yet. Also, why not just perform myomectomy? You can potentially create another fertility problem, and this is intrauterine adhesions, of course, apart from other complications of the hemorrhage and so on. So these are 3 recent studies just published last year, and they show a rate of around 10 to 20%. In this study, it was up to 36%, depending on which group. So submucous fibroids were associated with the highest risk, and this is exactly those that are very tempting to remove for fertility. The larger the area is, the higher the risk for uterine adhesions, if it's multiple fibroids, opposing fibroids, and multiple surgeries. Luckily, the adhesions in most cases were mostly mild to moderate, but it's a complication that can fire. So, can we conclude it all? What should we think of fibroids and fertility? So we can't really conclude, but it seems that the location of the fibroids have more impact on fertility than their size. The intermediary, so you 0, 1, 2, seem to be relevant, but this will not apply in all patients and in all settings. So most relevant in a fertile patient, or maybe not a patient that never attempted to become pregnant. The intramural type 3 uncertain significance, and the subserious, so those, and intramural ones, so those far away from the cavity, have likely little or no effect at all on fertility. And there is no clearly documented benefit on myomectomy. So proper fibroid mapping, because we can't just say this is the one fibroid treated like this and this, we have to choose an individual. So fibroid mapping is a really good start for patient care. And now I will come to the ultrasound part finally. A typical report that we uterus is large or not, and that's it. But as you now learned, we really need to know, where is it? Does it affect where fibroid mapping comes to? And I will now explain you how I use transvaginal ultrasound, and I have the image the other way around compared to Francesca. So here I always start slowly swiping with the transvaginal probe, always swiping from the left to the right and then back. I need to get an overall impression before I do anything. You really need to have to the other edge. Then you repeat this you twist the probe 90 degrees and you repeat it. You always have to start like this. And then you just things. You usually would choose with an enlarged uterus, low frequency. It gives you better penetration, but also a loss of resolution. So not always scan on the penetration mode. And then when you've done this, you start documenting one by one fibroid. We start on the right. And this is the painful part. You can use the fibroid measure tool on your machine. You can just use the caliper tool as I show you here, and then just take images and store them on your machine or in your viewpoint or in your system if you have this. Many units do not have this. Many doctors have a chaperone or nurse in the room while they're scanning. You can ask them to make notes and just write them all down for you. Or you can also consider making a sketch, and I'm a really fan for this. So this is how a possible report could look like. So you would, of course, do a general description of the uterus, and then I write the corpus is enlarged with multiple fibroids as follows, and I would also say how large it is, how mobile it is, because this is really important for surgery planning. And then you just start numbering them 1, 2, 3, 4, and up to 12 or whatever you have. So I say posterior left fundus type 5, and then I also write intramural because it's easier for people to read. And then I start with the diameters and always the largest one. Fundus, anterior, and so on. So you can sort them from left to right, or you can sort them by size. Usually I like to sort them then by size. And I add a little sketch, really simple like this. Some units have also forms for that. You can scan this, put this in the patient's file, or scan this in the electronic patient file. What I like to do, what I think is really important, is to give some clinical correlation. And in a summary, I write fibroids number 3, 4, 5, or whatever can cause heavy menstrual bleeding, or could be the cause of the patient's heavy menstrual bleeding, or maybe at this point all fibroids are asymptomatic and of no clinical relevance, because if the patient is symptomatic. So I think it's really important to correlate this to the presentation of the patient. This is another sketch. This was a woman with 2 massive fibroids, one 11 centimeters, the other 12 centimeters. And it was really difficult to see anything and to explain to my colleagues how they were located. So I just made this little sketch and they were like, aha, now we understand. So I'm really a fan of sketching. Again, the adjusting the image, lower frequency, you can see here, this is the same patient. And sorry, this is not so parallel, it is technically difficult to get, but you can see the outer contour on the lower frequency of the penetration image is better on the right-hand side than on the left-hand side. Maybe not massively, but if you have large fibroids up to 9 centimeters, you really need to go lower with your frequency, and you will be surprised how well you can depict those fibroids. As I said, it's really important to assess the proximity to the cavity. The 2D, of course, but also 3D can come in handy. This was a 47-year-old woman. She was referred with anemia. She had a community scan a couple of months ago and told there were small fibroids, but not the type or location or even the significance was documented. So you can see one fibroid here, and we can see on the 3D scan the coronal plane that one fibroid is completely inside the cavity and the other one is partially intramural, and we can measure this, and it's under 50% inside the myometrium. So this is a type 1 fibroid, which would be very nicely accessible for hysteroscopic resection. Here as well, it's really important to map, is this type 0, 1, or 2? You can't see this because the cavity is not visualized. This woman just bled so heavily, the endometrium is not visible. And in this case, you should use saline contrast, so a little tube through the cervical canal and fill it with some sterile saline. And there we can see, again, we do the measurement and we can see it's under 50% inside of the myometrium. So it is also a type 1 fibroid. If you combine 3D with saline, you can even enhance the accuracy, and you can have those lovely images where you see the cavity filled with fluid, the endometrium, and here is a fibroid. Well, this looks very marvelous and very easy, but the reality is often not the same. This is the same patient that I showed you on the how I do it image. So multiple fibroids, I took a 3D, not optimal, you see a little bit is missing here. And you can't always expect to see the crisp cavity like on this other image that I showed you. And there you have to work more dynamically also with a 3D. And I will show it on this video. This is from the 4D view. I have to tilt the whole plane, the image here in the 3D format plane to really show the whole cavity, and then I scroll through the cavity to see if and how the fibroid affects the cavity. And this was after I installed some saline into the cavity. So it looks not so convincing, but it's the best I could do in this patient with multiple fibroids. Another application is, for example, that you can scroll through the A plane in a 3D volume, and also while you take the volume and just look at all the fibroids here popping up one after another. This can also be done offline. But I would like to warn you, people think that 3D will cure all their problems with visualizing fibroid, and it's not. You really need a good 2D image first. And especially if you have massive fibroids, it's quite useless to have the 3D. In many cases, you will be combining transvaginal and transabdominal ultrasound. For example, in this case, the sketch, you remember it, I started here with transvaginal ultrasound and could visualize the cervical fibroid, which was down here. I could also then see here is the lower segment of the uterus, and the upper fibroid, the corpus, was not visible. And here as well, then switched to transabdominal, and lovely view of the other fibroid, which was in the fundal area. This is another case where this here is 9 centimeters. You can see it on the little sign here. The uterus was massively enlarged, and I couldn't really get a good view. It didn't look like adenomyosis. It didn't look like a fibroid. And abdominal view gives you a really crisp, even if the woman was quite obese, a very nice and crisp visualization of the corpus. Unfortunately, this was a sarcoma. We have a case here, a 35-year-old, never been pregnant, 5 years of infertility, a bit unclear why she didn't attend any service for that. She had an asymptomatic fibroid. She had normal bleeding pattern. And so far, there was no attempt of any IVF. There was unclear male factor, hasn't been tested yet, but she was already referred to myomectomy. And here in this case, I want to illustrate how an individual approach and also taking other clinical features into account is really important. So we can see a single fibroid. It's about 6 times 4.5 centimeters in size. And if we look closer, we can see there is a myometrial bridge between the endometrial cavity here and the fibroid. And we do a 3D, and we can confirm that there is a good margin between the endometrium and the fibroid. So it's a FIGO type 4. It does distort the cavity in part, but most of the cavity is not affected. And also she has no heavy bleeding, so we weren't sure, and she's never been pregnant. So we have then team meetings with multiple specialists, and in this case we recommended to first try an IVF, because it could be some embryo implantation problem not related to the fibroid. This is another woman. She was 42 years old, never attempted to get pregnant. She was single, so she had an active desire for child and attended the IVF service. She was primarily referred to myomectomy, but here as well we can see multiple fibroids. And also here we had to do a saline, and the image does not look overwhelming, but again, it's the best you can do. On 3D, we see one of the fibroids here and the other one there. And while on 2D, it looked like they did affect the cavity, on the 3D, it was less prominent. In her case, there was many other aspects to consider as well. Her age, the ovarian reserve, and the egg quality could be much more significant than her fibroids. If we would do a myomectomy, there would be a delay. And then also she has so many fibroids, which one would you remove? There's almost nothing left of her uterus in the end. And also uncertain benefits. So in her case, we did a hysteroscopy to really have a better look again, and then recommended to try IVF first and see if there's any a response from the ovaries on stimulation. Assessment of vascularity. I'm sorry, I feel I am going a bit over time. I will hurry up now. The assessment of vascularity can be relevant to discriminate from adenomyomas or to make therapeutic decisions, for example, if they're suited for embolization or hysteroscopic resection. And then again, some unusual appearances of fibroids, which you want to then specifically add in the report. For example, this could be a lipoleiomyoma, which is hyperechoic of content and has a hypoechoic halo, or a cystic degenerated fibroid, which can look quite scary. Sarcoma features. Sarcomas are really rare. You should be a bit wary when they're very inhomogeneous, if they have irregular borders, if they're breaching the cavity, they have cystic areas or this cooked microwaved aspect, a lot of Doppler flow, no calcifications, and no radial shadowing. You will find much more in this lovely paper on the standard terminology, how to describe the fibroids closer. So to conclude, fibroid mapping is to describe for every fibroid the location or the area in the uterus, the FIGO type, the size in 3 dimensions, possibly the specific features, potential clinical relevance. Use saline hysterosonography to assess the affection of the cavity, and always correlate with clinical presentation, look for adenomyosis and endometriosis, and then this will enable you to really make a proper and individualized strategy for your patient. Thank you very much.
Tina, a bit slow there. Sorry, I was a bit slow getting my video on. Tina, great talk. Thank you. I just think it's such an interesting topic, such a common problem. And I guess, Theo, you must see quite a lot of this, I think. I mean, and it's hard to know. I always think these balanced decisions and having a conversation in the MDT is always terribly important. But you did mention sarcoma, which of course is a bit of a thorny issue, isn't it? I mean, I think that is always a slight concern, especially after some of the very well publicized